Hello, Abby. My name's Amy. Please may I examine your face?
Yes.
First, test light touch sensation.
I'm going to touch your face with some cotton wool. Please could you close your eyes and tell me when you feel me touch you?
On both sides, test the three divisions of the nerve, the ophthalmic, maxillary and mandibular.
Now. Now. Now.
Repeat the test for pain sensation.
I'm now going to touch your face with a small pin. Please close your eyes and tell me if you feel it sharp.
Carefully test each of the three areas on both sides. Be aware that brainstem lesions may cause sensory loss in an onion skin pattern. Carefully dispose of the sharp.
Yes. Yes. Yes.
Use an orange stick to test touch on the anterior 2/3 of the tongue.
I'm going to touch your tongue with this. Please close your eyes and stick out your tongue. Thank you. Do you feel it the same on both sides?
Yes.
You can also ask the patient to indicate with a hand when they feel you touching them. Assess the motor function now. Look for wasting in the muscles of mastication.
Please clench your teeth.
Feel the bulk and contraction in the masseters.
Please open your mouth against my hand.
Carefully provide resistance to mouth opening, testing the pterygoid muscles. Next, test the corneal reflex. Draw out a wisp of cotton wool and dampen it to form a gentle point.
I'm going to gently touch your eye. Please look up for me.
Gently depress the lower eyelid and lightly touch the edge of the cornea. Look for direct and consensual blinking. Lastly, the jaw jerk reflex.
I'm gently going to tap your chin.
Ask the patient to let their mouth hang loosely open. Place your forefinger across the midline between the lower lip and chin. Look for reflex closing of the jaw. An absent or minimal response is normal.
Thank you. Hello, Abby. My name's Amy. Please may I examine you?
Yes.
Stand behind the patient for the whispered voice test.
I'm going to whisper in your ear. Please can you repeat after me what I say?
Mask hearing in the contralateral ear by rubbing the tragus. Use a variety of numbers and letters and perform the test in a quiet room.
I'm going to do the same in your left ear.
Start at about 15 centimetres. Hearing a whisper at 60 centimetres approximates to unimpaired hearing. Hearing loss should be formally measured with audiometry. Use a tuning fork to help differentiate conductive from sensory neural hearing loss. First, Rinne's test.
Can you hear this?
Yes.
Tell me when you hear it stop.
The base of the vibrating tuning fork is gently pressed against the mastoid process.
Can you still hear it?
Yes.
This demonstrated that air conduction is better than bone conduction, which is normal. Air conduction relies on the function of the outer and middle ear.
Again, can you hear this?
Yes.
Tell me when you hear it stop.
If sound transmission through bone is greater than that through air, then the test is said to be negative. This indicates conductive deafness. For Weber's test, place the fork in the midline.
Does this sound louder in either ear?
Normally, the sound is described in the middle and heard equally in both ears. Interpretation of both tuning fork tests is more subtle than it initially appears.
Forward for me.
The Dix-Hallpike manoeuvre can elicit positional vertigo due to vestibular disease. This vigorous manoeuvre is not suitable for all patients. When the patient lies back, the head should overhang the edge.
I'm going to lie you down rapidly and turn your head to the side. Please could you look straight into my eyes?
The patient's head should extend 30 degrees beyond horizontal and rotate 45 degrees to one side.
Do you feel dizzy or sick?
No.
Watch the eyes carefully for nystagmus. It may take 20 seconds for this or symptoms to occur. The pattern of response can differentiate between a lesion in the inner ear or central nervous system. Repeat the test, turning the head to the other side.
Thank you.
Hello, Abby. My name's Ben. Can I examine your hands?
Yes.
Just hold them out in front of you on the table.
Look for muscle wasting,
And roll them over for me.
particularly in the thenar and hypothenar eminences. Then test the function of the nerves in turn, starting with the median nerve.
And with your right hand, lay it completely flat on the table, keeping your thumb close to your palm, point it up towards the ceiling,
Test for power in thumb abduction.
and relax. And now touch the tip of your thumb with the tip of your little finger. Make a pincer grip. Don't let me break it.
And power in opposition.
And relax.
Next, we test the muscles supplied by the ulnar nerve.
And roll your hand back over. And now I want you to grip the card between your little and ring finger and stop me from pulling the card away.
Testing adduction of the little finger.
Relax. And now I want you to push out with your index finger against my index finger.
And abduction of the index finger.
I want you to grip the card, like me, with the sides of your thumbs and your index fingers, and don't let me pull it away.
If adductor pollicis is weak, the patient will flex the thumb in order to grip the card. Next, we test radial nerve motor function.
Can I take this hand?
Starting with finger extension.
Now push your fingers out straight against me.
Then wrist extension.
Now push your hand up against me.
And finally thumb extension.
Now point your thumb up towards the ceiling and stop me from pushing it down.
Next, we test the sensory functions.
And now rest your hand on the table with the palm facing up. Can you feel me touching you there?
Supplied by the ulnar nerve,
And there?
the median nerve,
And roll your hand over.
and the radial nerve.
And can you feel me touching you there?
Yes.
Thank you very much. Hello, Omar. My name's Ben. Do you mind if I examine you?
No.
With the patient adequately exposed, look for asymmetry. Inspect both proximally and distally. Note any deformities such as clawing of the hands. Look for muscle wasting or hypertrophy, fasciculation or involuntary movements. Fasciculations are often elicited by flicking the skin over a muscle.
Just let your arms go floppy for me.
To test tone in the upper limb, hold the patient's hand as if shaking it. Use your other hand to support their elbow. Rotate the forearm, flex and extend the wrist, elbow and shoulder, varying the speed and direction of movement. Muscle tone is the resistance felt by the examiner when moving a joint passively.
Again, let this arm go floppy.
Always compare sides. Muscle tone can be pathologically decreased or increased. There are two principal types of hypertonia: spasticity and rigidity. Next, examine the deep tendon reflexes. The biceps jerk mainly incorporates the C5 nerve root.
And relax.
Use your finger or thumb to palpate the biceps tendon. To test the supinator or brachioradialis jerk, the forearm is in the mid-prone position and you strike the tendon overlying the distal end of the radius. Move the patient's arms to allow a good approach to the triceps tendon. This reflex involves C6 and C7. Eliciting reflexes and deciding if they are normal requires practice. Use reinforcement whenever a reflex appears to be absent.
You're going to strike your arm again. When I tell you to, clench your teeth, but not before I tell you to. Clench.
For the upper limb, ask the patient to clench their teeth or make a fist with the other hand.
Relax the hand.
For the finger jerks, place your middle and index fingers across the palmar aspect of the patient's proximal phalanges. Tap your own fingers with the hammer.
Relax.
And look for flexion of the patient's fingers. To test the Hoffman's reflex, place your right index finger under the distal interphalangeal joint of the patient's middle finger. Using your right thumb, flex their distal phalanx downwards and look for the pathological flexion response in their thumb.
Can you hold your arms up by your side like that for me, please? Stop me from pushing them down.
Power in abduction.
Stop me from pushing them up.
And adduction.
Now hold them out in front of you like that. Stop me from pulling them away.
Elbow flexion.
Stop me from pushing them in.